Hello, hello. Hi. Okay. We are ready? Okay, finally. We're here. Thank you so much, Belen, for being here. Welcome back to another AJL Symposium here from Vienna, Austria, together with Ophthalmo University. We're very happy to be again together working on this incredible symposium. Today, we're going to have great speakers, outstanding KOL, key opinion leader in the cornea and anterior segment field. We're going to start right now with Belen Alfonso. She's from Spain, of course, from Instituto Fernández Vega, and today she brings a great talk about a new device, NeoRing.
Yeah.
It's a new device for cornea. Let's see what she brings for us. Belen,
Okay.
welcome, and thank you so much for being here.
Thank you so much for your kind presentation. And now we are going to start talking about a new pre-desthemetic corneal ring called NeoRing in deep anterior lamellar keratoplasty for moderate and advanced keratoconus. We are going to present this study that which purpose is to evaluate the morphological and functional results of the implantation of a new PMMA pre-desthemetic corneal ring during DALK in patients with keratoconus. This is a prospective study, and with this study we obtain the CE marking. First of all, we must start talking about the astigmatism that we can find in patients with DALK due to keratoconus. This astigmatism could be low, moderate, or high, symmetric or asymmetric, and also with the rule oblique or against the rule. The origin of this astigmatism could be on the donor, on the host, or also on the surgical technique. And also this astigmatism could be stable or progressive during the postoperative period. We also must talk about the complications that we can find in patients with DALK due to keratoconus, and these complications could be the short-term complications, secondary to Descemet's membrane ectasia, like steep keratometry, or central linear or concentric folds, as you can see in this picture. And also could be secondary to the thickness inconsistencies, like anterior or posterior steps, usually on the lower half of the cornea, and ocular surface alterations, and an early astigmatism, against the rule. Also, we must talk about the long-term complications that can be a recurrence of keratoconus in the donor, that we know that it's already described in patients with penetrating and lamellar keratoplasty, and the progression of keratoconus in the host, that we know that are described in penetrating keratoplasty but not yet in lamellar keratoplasties. And also we must remember the metallic chromate ring that is described in patients with keratoplasty. It was used initially for PK and was implanted at the graft-host interface between the two corneas. The purpose of this metal ring is modulate the healing, but also we know that can reduce the final astigmatism and also the reduced immune reaction. Our group has experience with this metal ring in 5 cases of DALK due to keratoconus. In these cases, the ring was implanted in a pre-desthemetic pocket in the host cornea, and we obtained good morphological and functional results with a low astigmatism. The problem here was that the economic cost was high and the aesthetic aspect too obvious, as you can see in these pictures. For this reason, we consider the development of this pre-desthemetic corneal ring that has a circular section made of PMMA. It has also a thickness of 0.20 millimeters, and this NeoRing is available in 3 diameters, 8, 8.5, and 9 millimeters. The objective of this implant in patients with DALK due to keratoconus are, in the short term, add thickness to the host cornea and obtain low and symmetrical astigmatism below 4 diopters, and also in the long term try to reinforce the host cornea. So in this prospective study, we included patients with keratoconus with indication of DALK. The best corrected visual acuity before the DALK was equal to or less than 0.5. The mean keratometry was greater than 50 diopters, the mean central pachymetry less than 450 microns, and the axial length greater than 23.5 millimeters. In the sample, we included 10 eyes of 10 patients with a mean age of 36 years old, and the minimum follow-up for all the patients was 24 months. So, regarding surgery, as you can see in this video, a conventional trephination of 8.0 millimeters were performed, with a manual dissection of the stroma, starting of the aids of the trephination using the Anwar technique. In these cases, we left a residual bed of 50 or 75 microns measured by ultrasonic pachymetry. As you can see here, we make a peripheral pocket of 8.5 millimeters where we introduce the nail ring. And finally, we place the donor cornea, which will be oversized by 0.25 millimeters. And then we perform the 16 sutures, the stitches. Here we have the surgical images of the first 5 patients in the study, and here those of the last 5. We can see how there were no intraoperative complications in any case and how ring implantation was possible in all patients. Regarding the results obtained, here we can see the first 5 patients operated on 2 years after surgery, and here the last 5 patients. So if we start talking about the complications, we haven't found faults in the cement membrane, anterior or posterior steps, or alterations in the corneal surface. Just in one case, we saw an early astigmatism against the rule. Also about the possibility of a recurrence of keratoconus in the donor cornea or of a progression of keratoconus in the host cornea, we will have to be assessed in a few years. If we talk about the thickness consistencies, as you can see here, the host cornea with the near ring is always greater than the donor cornea, avoiding the posterior step. In this table, we can see that the thickness of the recipient cornea behind the ring, also the thickness of the host cornea in the area of the ring, and finally the thickness of the donor cornea in front of the ring. So, without the ring, the thickness of the donor cornea would always have been greater than the thickness of the host cornea. For this reason, when we use this new device, this near ring, no significant previous or subsequent steps have been observed. Regarding the visual acuity and refraction 2 years after surgery, we can see that all patients have a refractive astigmatism less than 3 diopters, which is related to the keratometric cylinder. Also, the corrected distance visual acuity is greater than 0.7 in all cases. And if we analyze the keratometry, the endothelial cell density, and the pachymetry, we can see that are within acceptable limits. So regarding the evolution of the data, we can highlight that from the start of the suture removal 6 months after surgery, the refractive cylinder is lower than 4 diopters, and the best corrected visual acuity improved during the postoperative period. So, as discussion, it's important to remember that when we analyze the results related to the DAL technique, we observe that they are different depending on the initial pathology of the patients, and also are different depending on the surgical technique, a desthemetic or pre-desthemetic technique. So there is a mixture of content and concepts that we must take into account when comparing the results. So if we compare our results about the refractive astigmatism and the sphere, you can see that our results are similar than the results of Salotti that use the same surgical technique, a pre-desthemetic technique, but they use a more large trephination of 8.5 and 9 millimeters. And that's important because nowadays the options that currently described to prevent complications in patients with gout due to keratoconus refer specifically to the surgical technique, mainly the use of different diameters in the trephination. So, if you use an equal diameter between the donor and the host, it leads to decreased keratometry, but faults of the cement membrane are not avoided. But if we use a large diameter of 8.5 or 9 millimeters, both could be avoided, but the postoperative risk are increased. Also, if we talk about the femtosecond laser, we know that would also allows us to create a smoother, more perpendicular edges, but we only can use this kind of technology when we have an early stage of keratoconus. So NeoRing as a prevention methods provide us with consistent thicknesses between the donor and the host. It could be an effective long-term booster in the host cornea to prevent the progress of keratoconus. So as conclusions, NeoRing in DALK for keratoconus is a recommended procedure with unacceptable modifications of the surgical technique. The thickness inconsistencies are avoided and good morphological and functional results are obtained, being considered an effective and safe technique. But only over the years we will see if in addition it prevents the sclerotia. Thank you so much.
Thank you so much, Belen. Amazing talk, great presentation. I just want to ask you if you consider for every lamellar anterior transplant this device, and if you advise for all of us cornea surgeons to use it, to use the NeoRing for all our transplant, because your results are so good.
Of course, we think that we must use this new implant, but not only for patients, for keratoconus patients, even we can use this device in another pathologies, but the main indication in these cases could be this, no? Patients with keratoconus that has a thinner cornea, we can provide this thickness in this part of the...
Excellent, excellent. Well, thank you so much for your time. It was an enormous pleasure to have you here. And well, hope to see you soon here in AJL Simposio next year.
Of course.
Thank you so much. So we had the first presentation, and now come we can say the original, or she's the original.
She's the original.
She's the good one.
The good one.
She's the good one. Okay, now the father of Belen, Dr. Jose Alfonso, he doesn't need any presentation. Thank you so much for being here, doctor. We're going to talk about another incredible device for cornea surgery. It's the Endo K Pro, and Dr. Jose Alfonso will present excellent results, and he will teach us about this procedure and about this device. Thank you so much for being here.
Thank you.
Time is all yours.
To change the presentation, it's possible to change. Change. Lo que debería no es. Good afternoon. Thank you for the company, Andres Benati, to invite this presentation to do this presentation. And well, we are going to present a new concept of corneal transplantation. We have named it pseudo-chamber protected keratoplasty with Endo-K implant. The Fernández Vega Institute received an economic contribution for research in relation to the product Endo-K. Well, Endo-K is an intracorneal implant developed at the Fernández Vega Institute in collaboration with the AJL Spanish company, and which is already available on the market. As we can see in the figure, the implant consists of a peripheral ring, a transparent central disc, and 4 spokes. The implant is placed between the host cornea and the donor cornea, as we can see in these images taken with slit lamp and OCT. The surgical step of the PPK with Endo-K can be summarized as follows. In the host cornea, we perform partial trepanation, lamellar dissection of the stroma up to predesthemetic level, and a peripheral corneal pocket. After that, we place the Endo-K on the stromal bed with the peripheral ring inserted in the corneal pocket and fixed by means of a provisional 70 silk suture. Finally, we suture a full thickness donor cornea 0.25 greater than the host diameter. The suture of the donor cornea with the usual 10-0 nylon should be performed above the peripheral ring of the endo-K. The last step of the surgery is to introduce VSS or viscoelastic in the pseudochamber to separate both corneas. In this video, we can see the surgical technique in a patient operated on 4 years ago. The reason for the transplant was a corneal edema without stromal vascularization. The patient also presented aphakia, anterior and posterior synechia, normal intraocular pressure, and no previous vitrectomy. As we said before, the surgical steps are 4. Lamellar stromal dissection with Meles spatula, dissection of the predesthemetic pocket, fixation of the endo-K with 7-0 silk suture into the pocket in order to facilitate the suture of the transplant, and finally suture the full thickness graft with 16 nylon stitches above the peripheral ring. This is the normal procedure, the normal technique, and you can see the steps is very easy, the normal step of a lamellar keratoplasty. The first stitches of silk is only to maintain the cornea, the donor cornea, without problem with the suture. The second case is a patient with previous retinal surgery and intraocular silicone oil. The characteristics of the patient is no previo graft, corneal edema, posterior synechia, posterior chamber IOL, control intraocular pressure with drops, and retinal surgery with silicone oil, intraocular silicone oil. This is the suture, the provisional suture of the endo-K in the pocket, with a 7-0 silk. This is the usual, habitual, usual sutures, only to provisionally fix the endo-K, and after the normal suture of the donor cornea. In the postoperative period, we have 2 options. Maintain the receptor stroma bed if we want or need to protect the donor cornea of the intraocular pathology, or remove the receptor stromal bed below the central disc. If we want to improve the patient vision, or in this case, we can use the JAG laser, the femtosecond laser, or the vitrectomy scissor, depending on the thickness of the residual stroma. In this slide, we can see 3 examples of this second option. The next video is the method to removal of the recipient stromal bed. This stromal bed includes deep stroma, the cement membrane, non-functioning endothelium of the host cornea. Can be performed with a femtosecond laser, as we see in this video, or with a vitrectomy scissor. To remove the cut stroma, we enter with a vitrectomy forceps through a 20 gauges limbal incision below the stromal bed. This maneuver can also perform with the JAG laser, with the condition that the thickness of the bed must be less than 75 microns. The indication for the techniques are all those cases considered to have a bad prognosis for a penetrating keratoplasty. Eyes with corneal pathology associated or not associated with complicated intraocular surgery, or cases of trauma, or even previous failed transplant. From August 2018 to the present, we have operated on 71 patients of PPK with endo-K. All of them very complicated cases, with various associated pathologies. To classify the surgical indication, we assess 6 parameters: previous corneal transplant or not, characteristic of the cornea, iris morphology and function, aphakic or pseudophakic eye, intraocular pressure status, and previous retinal or vitreous surgery with or without silicone oil. In this way, we can easily define the profile of each patient. In this case, for example, the indication was justified by corneal neovascularization secondary to complicated surgery, and the patient had undergone vitrectomy with silicone oil. In this other case, however, the corneal edema was secondary to glaucoma surgery with valve implantation. The follow-up of patient is very simple and is based on the control of 4 parameters like the corneal transparency with the slit lamp, the evolution of the pseudochamber with anterior segment OCT, the evolution of the endothelial cells with a specular microscope, and the intraocular pressure with eye care tonometer or digital tonometry. This slide summarizes the results of the technique in the best cases. We will only comment the endo-K cases without previous penetrating keratoplasty at its longest follow-up. These cases are the best to start performing the technique. So we see that of the 39 operated eyes, 31 maintain a transparent cornea with an endothelial cell density greater than 500 cells. The rest of the patients have received a new transplant or are pending to perform it or have preferred not to perform more surgeries. In total, more than 90% of the operated cases have been resolved. On the other hand, to resolve 39 cases, we have needed 48 corneas, 1.23 corneas per case, similar ratio as when the first endothelial keratoplasties begin to be performed, for example. In the cases in which endothelial microscopy could be performed without difficulty, that is, without edema, a maximum in endothelial density was observed at the 6 month, and then a slow but progressive decreases over the months, but always maintaining values above 1,000 cells per square millimeter. To date, the main identified cause of endothelial cell loss is peripheral contact of the residual stroma with the donor endothelium. Among the intraoperative advantages of the procedure, we have the most important: to perform a closed chamber surgery, and therefore the possibility to combine another surgery such as cataract surgery. In this video, for example, we present an endo-K combined with lensectomy for advanced cataract. In this case, the cataract was very hard and extracapsular extraction was performed without lens implantation. We can see what is the maneuver to remove the cataract. We use the hook, the iris hook. I perform a scleral incision and also perform the cataract extraction, only the cataract, not implant new lens. This is patient with no prior transplant, corneal thinning secondary to ichthyosis, anterior and posterior synechia. The intraocular pressure was controlled with eye drops and retina without surgery. I am using the same technique. You perform the cataract previous to the implant of the endo-K through the residual bed to obtain a very thin residual bed that possibility they perform the cataract, and after we continue with the transplant in the normal step, with the normal steps, with 16 stitches. You can see the scleral incision and the keratoplasty. Regarding the postoperative advantages, the non-perforation of the corneal brings less risk of immune reaction, intraocular infection, and endothelial damage. On the other hand, it is also possible to perform secondary surgeries to solve problems like intraocular pressure or retinal pathology. And finally, it is possible to perform safely a new transplant without the need to remove the endocay. In relation to intraoperative inconveniences, we cannot highlight any. Lamellar dissection with the classic Anwar technique could be one, but it is very important not to perforate the host stromal bed. So I don't recommend it, the big bubble technique in these cases. As postoperative inconveniences, we have first the protrusion of the residual stroma between the four spokes of the endocay. In some cases, a peripheral contact between both cornea can occur, causing a failure of the endothelial cells of the donor cornea. To avoid this problem, we have found four solutions. The first, to regulate intraocular pressure before or after surgery. The second, to make a hole in the stromal bed with a jack laser. The third, perform an injection of viscoelastic in the pseudo chamber using a 30 gauge needle through the donor cornea, just above of the endocay spokes. And finally, advance in the development of endocay and improving surgical technique. The objective of these changes is reduce the space between the spokes of the endocay and then separate both corneas as much as possible. We can see the evolution of this idea in this video. This is a patient with no prior transplant, corneal edema without new vessels, anterior synechia, pseudophakia, intraocular pressure control with surgery and drops, and no retinal surgery. The most important changes in the techniques is you can see in the slide. The diameter of the host must be today 7.75 millimeters. We use the endocay of 8.5 millimeters. The diameter of the donor 8.25, and so the pocket to put the peripheral ring of the endocay 0.75 millimeter more than host. So 0.5 millimeter bigger the donor of the host, and also use the endocay with 8.5 millimeters. This is our standard procedure today. With these changes, we are avoiding the possibility of contact between the residual bed and the endothelial of the donor. Another postoperative problem is the appearance of a fibrin membrane inside the pseudochamber covering the prosthesis. This membrane is typical when we have new vessels in the host residual bed. To prevent the appearance of fibrin, corticosteroid treatment should be maintained as in conventional transplant. As a last drawback, we have the presence of the residual stromal bed, which logically limits visual acuity depending on its thickness. If the visual prognosis is good, a hole is made in the receptor stroma below the central disc. When the thickness of the residual stroma is between 50 and 75 microns, the jack laser can be used to make the hole. When the stromal bed is larger than 100 microns, the femtosecond laser or vitrectomy scissor should be used as alternative. Well, in conclusion, we can say that the new endocay intracorneal implant allows a full thickness corneal transplant without the need to perforate the cornea. It is the most important target, not perforate the cornea. It is an effective and safe procedure with multiple advantages and it can be an alternative to high risk of penetrating keratoplastia. Thank you for your kind attention.
Doctor, thank you so much. Incredible talk. Um, Congratulations for this device, for this develop. And I want to highlight two things. One, we improve the graft survival of the cornea because I saw the results almost 95% between 6 months and 48 months follow-up. And the other is safety because we work with a closed chamber, and that is so important, right?
I think this is important thing. It's the concept, the new concept, not perforate the cornea. When you have a patient that you are thinking that the possibility of endothelial keratoplasty, no, the lamellar keratoplasty, no, also, well, you only have the option to do a penetrating keratoplasty. This is the error, to do a penetrating keratoplasty. It's better to perform a lamellar, non perforating, to use the endothelial. This is the message, no? Not perforate the cornea, because in the future
you're going to have a problem.
you have problem.
And your conclusion were very, very clear. This is for cornea with poor prognosis.
Yeah.
We have an alternative to improve that prognosis, and I think that is the strong message here.
Yeah. Yes, thank you.
Thank you so much. A pleasure to have you here. Thank you so much. Okay, we're going to move forward. Now I have the pleasure to introduce Dr. Heikel.
Thank you.
Heikel Kamoun from Tunisia, and he's one of the. We don't have talk with him. We don't have presentation. Yeah. So we're gonna just it's gonna be a talk between friends. So he's one of the developers of AJL Pro.
Yes.
He has a lot of experience in intracorneal rings, and the first question that I have for you, doctor, is how or why do you think in a asymmetric corneal ring?
Okay. As you know, refraction is not vision, but shape is vision.
Okay.
And we know today to improve vision in keratoconus patient, you have to reshape the cornea in order to homogenize the cornea. And as Professor Alfonso described it in 2016, we have 5 phenotypes of keratoconus, and we have symmetric one and asymmetric keratoconus. And as you know, we have a very good result with standard ring in symmetric keratoconus, but not in asymmetric shape, which are DAC and snowman. So the idea started from there. So it's better to use asymmetric for asymmetric shape, and the best deal today is to adapt to each keratoconus shape the best ring profile.
Exactly.
So for that we developed asymmetric rings for
very clear
keratoconus.
For the public. So another question for DAC phenotypes. Do you think it's the best indication or the asymmetric corneal ring? Because we see
both
such a good results with DACs.
Yes, with DACs and also with the snowman.
Even
with snowman, you have to put 2 asymmetric rings,
and with DAC you
only
just one.
Only
exactly.
one. Yes.
Exactly.
Thank you very much.
Thank you so much.
And I would like to thank AJL for supporting me for producing such ring, because as you know, producing asymmetric ring is very difficult technically, and I would like to thank them for supporting me and for believing in my project.
No. Thank you so much, and congratulations for this amazing work. Thank you, doctor. Thank you.
Bye.
So, Dr. Kamoun from Tunisia talking about the asymmetric rings, and now I have the pleasure to invite here one of the most important speaker in keratoconus and intracorneal rings, a good friend from Argentina also, Dr. Carlos Gordillo. Carlos, welcome back, because we are...
Thank you very much, Andres. It's a pleasure to be here. Thank you to Ophthalmo University, to the company, and to all the colleagues that are here today. And well, the idea of this conference is to give some ideas and tips regarding the progressive rings.
Thank you so much for being here again, and let's go.
Okay, let's move on. So, do you have my presentation already? It's not here yet.
¿Cuál
Okay,
será la tuya?
P3.
Sí.
Yeah. Thank you. Okay, great. Well, thank you very much again for the invitation. It's a pleasure to be here. Thank you to Reyes, Felipe, and all the colleagues that are here today. So the idea of this presentation is to try to explain you how to perform the surgical plan and how to select the cases for the progressive rings. So the principal objective of this class is to identify the cases that require this indication, to understand the functions of the intracorneal rings, the techniques and the approach of the technique, and also to understand the steps of the surgical plan. So for that, I have to be very grateful with Dr. Alfonso that was here before, because he was the one of the doctors who teach me about how to select the patient, the type of intracorneal rings that we have, the variety of the measurements of the different rings, what parameters we should consider, and also it's very important to understand the expectations, the patient's expectations, and also our expectations. So as I was telling you before, Dr. Alfonso teach me with Dr. Fernandez Vega about the classification. So it's very important to understand the shapes, the parameters that will teach us in which kind of keratoconus we can use these kind of intracorneal rings, because you have different parameters, different phenotypes, and these intracorneal rings are not for all of them. So the idea of this slide is to show you the different types of intracorneal rings that we already have in the market, and the new ones is the progressive one. So far it's been 2 years since I started using these rings, and I'm really happy with the results and also the patients. So this is the intracorneal ring I was talking about, and I will show you some cases and how do I choose the patient and what you should do at the surgery room. So I always show this to my patients. It's like a worldwide map. It's always useful to understand how stepping is the cornea and which are the summits of this surgery. So once you have the patient selection, you need to make an interpretation of the topography. Then this is the most important part of the surgery, to understand the axis. You have the chromatic, the refractive, and the topographic axis. I will show you later how to choose all of them. Then once you have done that identification of the axis, you can choose the intracorneal ring, make the surgical plan, and then the technique is always the same, but with these intracorneal rings you will have some different specifications. So in this Congress in Vienna, we presented our 4 results in comparison of 3 different platforms of femtosecond to perform the tunnels. So I will share with you these results because with all of them it's really good. We studied 3 different groups in all patients with DAC phenotype using 3 different platforms. For each platform, I analyzed 10 cases with more than 6 months of follow-up. So you can see here the difference between one platform and the other one. I have the opportunity to use intralace femtosecond, Zimmer femtosecond, and lenses from Alcon House. So there you can see the difference between one another. For all the patients, I use the same tunnel. So you have the inner tunnel in 5.8 and the outer tunnel in 7.8, and then the deepness of the tunnel is going to be around 70 and 80% of deepness. So to understand it better, I will show you this case. In this case, you can see the topography, and also in the pentacam, you can look for the intracorneal rings display. There you will be able to identify the chromatic axis, the topographic axis, and also the refractive axis that you need to know when you make the refraction of the patient. As you can see there, you have more than 10 and 15 degrees between one and the other. That's good enough to choose this kind of rings. If you can see there in the picture, you'll be able to see the pupil. It's perfectly surrounded by the ring, so the position is it's perfect. So here you can see a video with the different platforms I was using for this study. All of them are safe enough and good enough to show the results. So the difference between one and another will be the surface. Two of them has like a plane surface and one of them has a curved surface. So the docking is also different between one and the other, and also you have to see always the center of the cornea. You need to take in account the center of the cornea, because if you have a platform like intralace or Zimmer, you'll have a plane applanation. So the center is going to move. You'll be able to see now how it moves in the intralace in the center of the screen. When you put the ring, the cone, there you can see how you need to move a little bit the cone and move the center of the cornea. After that, you'll be able to implant the intracorneal ring, and with all of them it's the same. Usually, you don't need to use any instruments to introduce the segment. And as a good tip, you will need to move a little bit forward from the incision, because it can move a little bit. If I have a progressive keratoconus, I also perform cross-linking, so that's why you'll see that I'm taking out the epithelium. So these are the results of this first presentation. The results were really good in all the cases, and we had like a huge improvement in visual acuity, considering corrected and uncorrected visual acuity. Also, you have a great decrease in the keratometry values, and the cylinder changed from a mean 5.8 to a mean 1.75. So it's really big. So apart from that, you'll see the aberrometry values, and there you can see the total value of the high order aberration, and how big is the reduction between pre-operative evaluation and post-operative evaluation. It's the comma values goes almost to the normal value. That's really important to see, because if you identify the value of the cornea before you perform the surgery, you'll be able to compare. And not only the patient will be happy because of the visual acuity, also because of the visual quality. So to be more clear, I'll share with you one case. So this is a 31-year-old patient with a high astigmatism that was increasing. So as you can see, the visual acuity was 20/50 and 20/40, and you have the patient had a potential of 20/25. So after performing the diagnosis of progressive keratoconus and corneal ectasia, you'll have to identify again the parameters I was talking before. The pentacam is really easy because it shows you in red all the values that are not normal. So once you identify that, you can also perform the progression display to follow up the patient and to see if it's having a progression or not. If you have a progressive case, you can combine the techniques with cross-linking. Otherwise, you can only perform the intracorneal ring. So for this one that was progressive in both eyes, I did a calculation. Again, topographic axis first, then chromatic axis, and finally the refraction axis. As you can see, again, you have more than 30 degrees of difference. That's a good reason to choose this kind of ring. So this is the ring I choose. Also for the left eye, you can see there the difference between one axis and the other one. This is really important to understand, because if you understand the axis, you'll be able to choose the proper ring. And this is after the surgeries. You can see the center of the cornea and the periphery of the intracorneal ring. Also, you can see the tomography and the difference between the intracorneal ring sizes, the progressive sizes. You can see it there. So in the 6-month post-operative evaluation, you are able to see the results with a great decrease in the astigmatism and a great improvement in the visual acuity. So from 2050 to 2025, and you will see how it changed and reduced the astigmatism and improves the visual quality and the visual acuity. Also the left eye. And here you have the comparative evaluation in the topography. So you can see the preoperative evaluation, the postoperative evaluation, and the differential map for the right eye and also for the left eye. So I have another case to share. This was a case also with a bilateral keratoconus, but in this case only the left eye was the one that wasn't with a good visual acuity. So I do it again. I put the topographic axis, the refractive axis, and the chromatic axis. There again you can see more than 50 degrees of difference between one and the other, and the dog phenotype. This is when I go to the surgery room, I perform the surgical plan, and there you can see the pre-operative and the post-operative evaluation. Actually, this was the first case I performed 2 years ago, and well, right now, after 2 years, I'm really sure, I'm convinced that this is the best option for this kind of phenotype. You can see there the post-operative evaluation. Actually, this was inside the surgery room. You can see the pupil is still small because I used pilocarpine before performing the surgery. So the last case, it's also a bilateral keratoconus, but this kind of different, it was not like that clear dark. So I decided to perform this intracorneal ring in the left eye. And you can see there the results, the post-operative results. In this case was huge, the amount of astigmatism that was able to reduce with the ring. You can see there the visual acuity and also the surgical plan. So sometimes you have different parameters or different phenotypes. This was like a duck, but the direction of the duck is horizontal, so it's different. I had to think about this case like a right eye, but it was a left. So the incision was different. I performed it in that way, and you can see there the difference between one surgical plan and after the surgery. So to finish, I'll give you my conclusion for this kind of phenotype, duck phenotype. This is nowadays, for me, the gold standard for the treatment of keratoconus, because it not only reduces the corneal aberration, it gives the patient a better and more visual quality and visual acuity. Okay, thank you very much.
Congratulations, Carlos. Thank you so much for your talk. It wasn't easy with the sun on your face, but
Okay,
you
no,
did
it
it
was okay.
great.
I did it.
It's the
It's
sunset.
alive.
Yeah,
Live.
exactly. We cannot do anything. So, Carlos, we were talking with Dr. Heikel. Do you think that now we are thinking, or we have a mindset that with the intracorneal ring, the asymmetric, we are thinking like refractive surgeons, looking for a refractive result as you just showed us? Because a few years ago, we just really wanted to reshape the cornea, right? Then contact lens, whatever. But now we are having great results, refractive results with these patients.
Okay, yeah, it's a good concept, but we always need to try to regularize the cornea. If you are treating the cornea, you need to be sure that you're doing the best to regularize the cornea. It doesn't matter if you, after the surgery, need to perform 1 year after an ICL, like a phakic IOL, because you're looking for the visual quality, and the refraction after the surgery, no matter you have a low astigmatism, you have a big quality of vision.
Exactly.
So the patient is really happy. Actually, they tolerate contact lens. They have very good visual quality and quantity with glasses. So after 1 year, if you have a big myopia, maybe you can offer the patient another refractive technique.
Exactly.
But it's like when I think about the technique, I don't think to take them out of the refraction. Actually, I tell the patient, for sure you will need sunglasses or contact lens until you finish your post-operative evaluation after 1 year. If you tell that the patient, you never will have a problem
He will
because you are
understand.
being clear.
Exactly. And the same question that to the other speaker, you said that the DAC phenotype is
Yeah.
one of the best results with this
It's
asymmetric.
amazing,
It's
yeah.
amazing, right? We are.
Yeah, actually, it's for me. I don't have another option for this kind of phenotype. And if you are a good, if you perform a good screening in keratoconus, you'll find this kind of phenotype at the beginning.
Yeah,
So-
absolutely,
so-
absolutely. Well, Carlos, thank you so much for your
Thank you,
time.
Andres.
I know you're super busy, so
No.
we really appreciate it.
It was really nice to be here. Thank
Thank you so much.
Bye bye.
Well, we're gonna move on. We are having a great symposium, and now with the sun on my face, it's here. We're gonna present the next speaker from France. Welcome, Dr. Sophie Kalel from Hospital des Queens. I don't know if I said it.
15-20.
Okay.
It's a French
I don't
name.
speak French. Okay, I'm
Yeah.
sorry, but for friends, let me help you with this.
Okay, I'll check
Yeah,
my
you can-
presentation.
Yeah, minimize. Okay, okay. So, Sophie, and we're going to talk about double progressive intracorneal ring segments.
Yeah.
Until the presentation is ready, can you tell me since when are you using this kind of intracorneal rings?
Okay, it starts with the first version of
Okay.
progressive intracorneal rings. It was with another company, and it was two kinds of intracorneal ring progression. The first version was only on the depth, on the thickness
yeah.
of the cornea of the ring. It works very well, and I tried with that like more than almost 200 eyes. Then, unfortunately, in France, the commercial stops importing this kind of rings. So, at that moment, we had another company with another kind of rings, which the progression is different because it was with the base. It worked, but not enough.
Okay.
And finally, and fortunately, like 2 or 3 years ago, AJL Pro provided a revolutional rings with double progression. I mean, in thickness and in base, and it's logical in our practice because the cornea of keratoconus is really not accurate. Cannot be simple progression in it, and it was a really revolutionary solution. Actually, I had so many patients. We had data of them, and we are very happy with it.
How
So-
many patients, Sophie, do you have with this new technique, this new AGL
Actually,
Pro?
between 180 and
Wow.
to more than almost 2,000 eyes.
Wow,
Yes.
wow, that's a lot.
Not thousand. Excuse me, hundreds.
100. Wow,
To
it's the same.
200 to 100
It's the same.
patients.
So you are more convinced that these kind of rings are a little bit better than just the progressive, the one
Yeah,
single
as I will
progressive.
show you, there is two family of keratoconus,
Yeah.
and there is a family of keratoconus with irregular cornea, which are really, which need really the progressive rings. So that's what I'm presenting today.
Okay, perfect. Sounds great. Sophien, I think we are ready. Yeah.
That's the second.
Okay. We can keep talking, but it would be great if you can fix it in the next 10 seconds. we're gonna do a break, and then we're gonna follow with the symposium. We're gonna wait just 5 minutes, and then we're gonna continue.
Ça va? So what's the problem now? Keynotes, yeah. It was in keynotes.
Well, for all the audience that we have, we're gonna uh, moving forward in 5 minutes. We have with a technical issue, but please don't leave because we're gonna be ready very very soon for all of you guys. Thank you so much.
Asma. shared, right? It will not be shared on. Okay, so it's not. It will not be. Okay, no problem. But just tell me when I have to start. You tell me whenever you want. I can go. Okay. Hi everybody. Thank you for the invitation. Today I have the honor to speak about the evolution or the revolution of the new intracorneal ring segment with the double progressive in the treatment of keratoconus. So as you know, intracorneal ring segment are these devices with the shape is or almost the shape and the thickness of rigid rigid contact lenses, and this is how it looks like into the eye and with an OCT image. So previously we had symmetric intracorneal ring segment, which was the first version of the corneal rings, and the procedure was very easy. For in my practice, I start with the markage of the pupil place in front of an anterior slit lamp. Then we use the femtosecond, and as you see, we can move the axis to be sure that the axis is on the right horizontal axis 0, 180 and in front of centered on the cornea. Then the laser goes, and with that way we are sure to have the axis corresponding to the shape, the real axis. Then the procedure is really easy. I have to make a small dissection, then we put the ring into the cornea, and the procedure is really easy to perform, no difficulties. And after that, we, in the first days or the first weeks of the cornea, we can imagine the ICRS function. Look into these two red lines. It looks like something going into the anterior chamber, and if we join these two lines, we can imagine like a myopic correction. And even in the front part of the cornea, I mean in the epithelial thickness, look at this place and look at the thickness of the epithelium in this place too. And if we join these two lines, we can imagine that it represents negative correction. So it depends. If it's circular, it can be a myopic correction, and if it's for astigmatism, it can be just oval one. This is a case of bow tie keratoconus with -7. We put two intracorneal ring segment symmetrical, and the results 4 months after looks like something much better with regression. This is a type of croissant with -6 of astigmatism. This needs only one intracorneal ring symmetrical, and 4 months after we have a very good result. And you see with the differential map that the shape of the regression corresponds to the rings. This is another croissant, but it is bigger, so maybe in this case with -11 of astigmatism, almost 12 diopter of astigmatism, we put 2 rings, and the result was not bad. We lose the half of the astigmatism. This is the nipple shape of keratoconus, and it needs a 320 shape rings, and the result is very good. So you have to understand that for symmetric keratoconus like bow tie, we should put 2 rings, similar things, in the crescent shape, 1 or 2 rings. It depends on the power of the astigmatism, and with nipple we can use only 1. For asymmetric keratoconus, which are the asymmetric bow tie or snowman, the asymmetric oval or the pellucid-like, like the lobster claw, in this case we cannot put symmetrical and normal rings, and in these cases we need to put progressive intracorneal ring segments. So the revolution is with this new AJL Pro product, which is double progressives. I mean, the progression of the thickness and the base is guaranteed in these rings. So you remember this function of the post-operative results. In this case, as you see, we put a progressive ring, and in the OCT we can see here the difference between the beginning of the ring and the end of the ring. And look at the posterior part. In this case, you see that the effect on the epithelium is better on the thicker part of the ring, and the effect is of course much important. And even if we consider the posterior part of the ring, we see that the effect is more important. And this is not the same as the beginning of the ring and the end. And as you see, the power cannot be the same, because even the thickness and the base are not the same. So the effect will not be the same, and of course there will be a progression. So the procedure is quite the same, so centered on the cornea with the laser, then a small dissection, which is very easy, but it's important to center the treatment on the center of the pupil when the patient is not laying down. Then we put the ring, and it's very easy to put and to respect the axis. The axis is really important to show. And at the end, the procedure doesn't lay there more than few minutes. So this is a case of a duck patient. So in this case, we put a corneal ring. 1 month on post-op, you see that the difference is very important. And if you compare, this is a very, very, very good result with minus 14.22, as you see in the bottom part of the screen. This is the result of 1 month. So this means that there is an overcorrection. But if you see 6 months after, in this case, we see that the progression is the result is a little bit much good, much better than the first one. So if we look at these 2 images, 6 months after, the post-operative differential map looks like less important. So this suggests that there is like a small regression. And if you look to these 2 maps and we make the difference, you see that there is a progression of in this map plus 6.36, which is not the keratoconus regression, but it's the overcorrection of the epithelial mapping, which changed. This is a case of a snowman. So we put 2 corneal rings. This is the result few months after. And look at the differential map. The difference is very, very interesting. This is inverted snowman, which needs 2 rings. The result is very good, and look at the differential map, which is exactly the effect we have to reach. This is a duck example. In this case, we put only 1 ring, a progressive ring at this place, and you see the differential map, which is very interesting, and the shape of the regression looks like the effect, the duck effect. This is a lobster case. In this case, the result was good with only 1 ring, and here we see that the differential map looks like more than 11.5 differential. We had 33 eyes in our study, but only duck type. We can say that uncorrected visual acuity and corrected visual acuity in 6 months we had win 2 lines for between preoperative and postoperative. 78% of our patients had at least 1 line of 2 lines of better visual acuity, with less sphere, with less cylinder, and a better equivalent, spherical equivalent. We had a reduction of 39% of the coma, and statistically significant results. So in conclusion, for symmetrical keratoconus, we need symmetric intracorneal ring segment, as in the bow tie, the crescent, and the nipple. For asymmetric keratoconus, we need, in this case, asymmetric and progressive intracorneal ring segment, like in snowman, duck, and lobster lobe. Thank you so much.
Thank you so much, Sofian. Excellent talk, excellent. Amazing results. 40% of reduction of the coma, that's great.
Yeah.
Right? For the patient, for the quality of vision.
Yeah.
I want to ask you, do you combine sometimes this procedure with cross-linking, for example?
Yeah. In some cases, it's needed to combine intracorneal ring segment and other procedure. It can be cross-linking or something else after that.
And you do cross-linking before, after, at the same time?
No,
It
the
depends.
logical plan is to perform first the rings
The
for
ring.
2 reasons.
Yeah.
Because the cornea is still soft,
Softer,
so
yeah.
we can do whatever we want with it, and then we can fix it and make it not moving much more with cross-linking.
I agree 100% with
Yeah.
that protocol. I do the same. But again, I'm impressed with the results. AJL Pro, I think they are a great tool for this kind of keratoconus. Thank you so much,
You're
Sofian,
welcome.
for
Thank
your time and for your patience with the issue that we had with technical issues. Thank you so much.
No problem. Thank you so much.
Okay, we're gonna move forward, and I have the pleasure to present Sofia Vitucci. This is easier for me to say your name. It's not French. So Sofia is from AJL, and she will be talking about some news that the company
Yes.
has for all of us. So Sofia, thank you so much for your time,
Thank you to you.
and the time is all yours.
Thank you. I will be quite fast. Let me find the presentation. Here we are. So, hi to everyone. I would like to introduce to who doesn't know yet our keratoconus service, who is a professional support that AJL give to doctors and whoever needs, in case he needs help for ring calculations or difficult cases for keratoconus. So anytime um, you can send all the data to ask us an opinion or information. We can personalize the calculation based on corneal topography, considering the curvature, the interior and posterior elevation maps, and of course the pachymetry, as we also take in account the aberration, so the coma with this magnitude and axis, the refraction of the patient, and the best corrected visual acuity. Of course, case history of the patient is always important. Additional information that we would like to consider, if are available, are the visual potential with rigid corneal lenses, contact lenses, and the surgical technique that will be used for ring implantation. So otherwise, online there is the AJL nomogram that can help for ring calculation to create the plan. So it's, as I said before, our calculations are based on corneal thickness, so the pachymetry, the aberration. We need information about asphericity, astigmatism, and coma, and also the keratometry, so the case value. It's easy to create an account, so if you don't have already an account, you can go to our page and just register, filling up the data, and be able already to straight away to log in. Of course, we have to introduce the patient ID, and important, the preference of the brand of the ring that you are considering, and accepting, of course, the license. So how we use our nomogram? So briefly, I can show you how introduce the data, in how present our nomogram. I show in the website. So first space is for the K1 and K2, so the keratometric value, the cornea, the coma, axis and magnitude, the pachymetry value, and the Q value. So after that, the nomogram will suggest a plan that is what we consider is the best, and that can be downloaded from a PDF with all the data necessary for the order and the implantation. Very important is that you can find different options in suggested by our nomogram. So very important is to know that in case this case is suitable for and can benefit from AJL Pro, so a progressive asymmetric ring, you can find it as a first option. Otherwise, you have option for 6 millimeter or 5 millimeters, depends on the case. So you can select the file, the PDF that you want to download. So as doctors better explained before me, I want to remind about AJL Pro, which is a symmetric intrastromal corneal rings with a double variation, with a double variable progression in base width and thickness. The arc length available is 160 degree and 2210. This is because is what the asymmetric phenotypes require. In clockwise and counterclockwise configuration depends on the shape of the ring that you need, and the optic zone is available in 5 and in 6 mil. So last but not the least, we want to inform that AJL will launch the AJL ring for regulatory reason. We have to introduce to this new brand that will have same triangular shape, same parameter and references as Ferrara, available in 5 and 6 octane zone, with all the thickness and the length as before. And it will be like a transitional period to switch and to pass completely to this new RAM. So that's it. I try to be very
Yeah, no, but
very
let me
fast.
tell you some. No, 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 it was great. But let me tell you something. I think this is the most important talk because you are teaching us how to make the plan. This is very important for all the people that are watching the video because you are a great support for the surgeons for the
Yeah.
very first cases when they have some doubts, when you don't know what kind of AGL ring you want to.
Yeah, exactly
put.
what I always try to transmit to new
Mhm.
doctors that start with this technique to the ring implantation.
Mhm.
It was is to give a support to confirm, to learn how to
Exactly.
select the best plan, the best option,
Yeah, absolutely.
and and support to confirm that their calculation is good, and also very important, even for doctor with a lot of experience. I know that there are many difficult and complicated cases, so maybe they are happy to ask questions because we can see many different difficult cases. So maybe
Absolutely.
we try to
And
give this support.
yeah, and always it's good to have the support of the company. Again, in those first cases, we have a lot of young people in Afternoon University watching this. They want to give the first steps in keratoconus surgery, and this is great because they are not alone. And always the first steps are the more difficult. You know?
Yeah. No, but it's
when
exactly
you are
what I
starting
feel.
the curve.
It's exactly what I feel every time I talk
Exactly.
to new
And
doctor because new to the technique, young or less young.
Don't freak out because
But
we
yeah,
have
absolutely.
great speakers, outstanding speakers with a lot of years of experience.
Yeah,
But
yes.
if they are in the first steps, AGL has the support for all of you guys.
Yes. So first, mainly at the beginning, they can concentrate on the technique, on learning, and
Absolutely.
we support for the calculation, which
Yeah.
is really complicated and it takes a while to be confident with the calculation, to understand the aberration, the effect of the aberration in vision.
Mhm.
So after that, when they are fine with the technique, I always take care to teach them how to play with rings, with plants. And then I always say it's a kind of art.
I
It's
saw
not
you
math.
in the wet lab teaching
Yes.
the doctor. She's very good. So if you are in the next, I don't know, meetings or when you see a booth of AGL, Sofia is always here
Yeah, we'll try to
with the
organize
wet lab, and,
a
and
wet
you
lab.
can take advantage of that. Well, Sofia, thank you so much.
Thank you to
We're
you.
gonna do the last break before Dr. Canabrava is here. He's running to here, so we're gonna do the last break is just 1 minute. Go to the restroom, get some water, and then we're gonna continue.
curve.
Okay.
Okay.
Well, finally we're here. Sergio, thank you so much for being here. I know you are.
You are live?
Yeah, we are live.
Yes.
Yeah, Ophthalmo University
Oh,
YouTube channel.
it's a pleasure
Yeah.
to be here.
So smile, please.
You didn't tell me it.
Well, that was a little surprise because you are the last one. So for the last one,
Is
for the
only
start.
because of Ophthalmo University and Race and the hotel, because my wet lab technique stay
in this at this moment.
English or Castellano?
In English.
In English. It's happening this morning.
So,
Okay,
yeah.
and because Pedro too.
Yeah, he left his own wet lab with his own technique for being here. Thank you so
Yes,
much, my
yes.
friend.
It's a
But
pleasure.
you're the best. The last one is the star of the night.
Mm,
We are going to talk about the learning curve about the Canabrava ring.
okay.
Again, thank you so much for your time and congratulations for this Canabrava ring that is a success all over the world. Welcome, my friend. Thank
Let's
you.
go. Let's go to discuss the learning curve. It's really important to start in any iris expansion ring with the easy cases. If you start with a hard case, it's really difficult and maybe you can have problems. So let's go. Step one to the learn curve. I just suggest to start with a pupil with dilatation between bigger than 4.5 millimeters, okay, to connect the ring. And so after you do 2 or 3 surgeries, go to the step 2, looking for pupils between 2.5 and 4.5 millimeters. And so after you stay with comfortable in this step, go to smaller than 2.5 millimeters and patient with synechias. So, step 1, observe. A perfect case to start, Y-to-Y diameter bigger than 11 millimeter, okay, it's really important. Our rings in the market, there is about 9 millimeters the overall. If you try to insert a ring with Y-to-Y diameter is small, for example, 10 millimeters, the ring can touch in the periphery of the cornea and you can have corneal edema. Don't matter which ring is, Canabrava, Oasis, iRing, Maliugin, all these rings there's about 9 millimeters overall. So start with case bigger than 11 Y-to-Y diameter. So here another good case, 3.5 millimeter, 4 millimeters, and with a large Y-to-Y diameter. So after it you can go to the step 2. You go to the diameter of the pupil between 2.5 and 4.5 millimeters. Here I will show a video for you. Observe. I back a little, I stop it, and how is easy to connect the ring in a patient with a large Y-to-Y diameter. Start with the small indentations. It's really important. I saw many surgeons, is the more experienced surgeons, because these surgeons see the video, oh, it's easy. Yes, but if you don't pay attention in the orientation of the ring, you can insert wrong. Observe, there is large indentation, even small indentations. If you don't pay attention in the side of the ring, you can insert wrong and it don't work. You need to understand the technique to start the technique. So observe this video. We start with the small indentation above the iris. And so in the left small indentation and the right small indentation. If you do like this, it is easy because it's need to think. The small one go behind the iris and the large one go up the iris. So you have these 2 hook stabilizations at the end of the ring, and with these 2 hook stabilizations go behind the iris. And so the 3 large indentations go above the iris. Is the most important point to you that you start with the technique. Okay, step 3, smaller than 3.5 millimeter. Please don't start with this case. Sometimes you see my videos on internet, oh, Dr. Canabrava do it so easy, but it's because I have a large number of patients. Please start with the easy patients, okay? So observe this kind of case. Patients with rouge synechia, or patients with extreme shallow anterior chamber, or patients without pupil. It's possible to insert the ring? Yes, it's possible. You can find many videos on internet. But please don't start with this kind of case, okay? Andres, the learning curve, but if you want to talk how to insert the ring, you want to talk how to remove the ring, because maybe it's
Yeah, sure.
difficult.
It's
What
up
you
to
want?
no. Yeah, it's up to you. I don't know if you have time or.
Yes, you have a little time.
Yeah,
I
okay.
told for the another instruction that you back 6 o'clock today.
Okay,
wet lab.
perfect, perfect. So we can do the other talk. Do we have it here?
Yes,
it's
I
another-
send by.
Okay.
I send it. Let me see. I send it by WhatsApp. Another best case to. Let me see the number two.
Okay. Just that. Okay.
I send two
Both.
presentation by. The two is like the same. I send you do with
Should
transfer link. Is the same one? Yes. The one link. Oh,
Okay.
no problem. You can
Okay.
discuss here if you want.
Yeah, absolutely.
We
Yeah.
can
Tell
discuss.
tell us more about these tips that the surgeon needs to know to start doing the Canabrava surgery technique.
Yes. The most important point is you need to check the side of the ring.
Okay.
Okay? You
Yeah.
need to have in mind that the large indentation stay up the iris.
Yeah.
If
Good.
you try to insert the ring with opposite side, the small one will be inside the iris. It don't work. And it's happening, especially with surgeons that have good experience.
Okay.
Because these surgeons see the video one time, no, it's easy, I will do. But the problem, the surgeons that stay with more calm, more study the technique, there is no problem.
Okay. So
Okay, this is really important.
we have to be confident, but not too much.
Not too
Not
much,
too
yes.
much, because has these little tricks, the
Yes.
technique that we have to learn, even when we are experienced surgeons. How is the remove technique, or what is the
Yes.
technique for removing?
The remove is another important point, because to remove the iris is easy.
Okay.
You connecting the large part of the ring and just pull and out. This part is okay. The problem is when the doctor try to go inside the eye
Okay.
with a McPherson force in the middle of the eye. It's not the way to do. As I show in many videos, you need to put the upside, the open side of the ring near to the main incision.
That
Near.
is a great tip.
If the open side stay down or up, it will stuck in the cornea.
In the corner.
So this part needs to be in the middle
Okay.
of the anterior chamber and is near to the main incision. If near the main incision, you go with the McPherson and rotate
Okay.
easily. The
Good.
problem is when the doctor try to remove it directly to the iris. You can't remove it directly to the iris. You go with a Sinski hook, put it in the anterior chamber, and so put in the middle of the anterior chamber, near to the main incision, and rotate it.
Okay.
Is the way to remove.
Perfect, perfect. So it was very clear. We have a lot of videos. Also, we have the other presentation in the Pan American with the videos, the techniques. If you can watch it, you can go to the ophthalmouniversity.com, the channel of in YouTube, and watch it again, the Sergio techniques. My friend, it was good. Thank you so much for your
a
time.
pleasure.
You can come back to your wet lab. Thank you so much, AJL, Felipe Reyes, for this amazing event. Hope to repeat soon. And thank you so much for the people who is connected. And we will see you soon. Thank you.
Thank you. Done?